Hey everyone, it's Dr. Dan Ritchie, president of the Functional Aging Institute, and I am joined by Dr. Bruce Crawford. And Dr. Crawford actually is a trained OBGYN, but trust me, we're not going to spend a lot of time talking about gynecology and baby delivery, but we are going to talk about how that fits into his talks at the Functional Aging Summit and his new education now in pelvic floor health, which is so critical as people age. I'd actually like to kind of start there, Dr. Crawford, with sort of your thoughts about the fitness industry and helping people with pelvic floor dysfunction and maybe a whole set of musculature that we don't typically train in the fitness industry or give much thought to.
Yeah, I'm happy to talk about that. You know, there's a big misunderstanding I've come to realize over the last 23 years of my career. There's a big misunderstanding about the origin of pelvic floor disorders. Now, most common among those are bladder control problems like stress incontinence or overactive bladder. But also, pelvic floor disorders include pelvic organ prolapse, and combined, those account for hundreds of thousands of surgeries every year in the United States. And the problem is, it turns out, these issues are fitness issues. They're not surgical problems. And they need to be reclassified, and the actual nature of these problems needs to be clarified for not just the general public, but for the people that are the health advocates for the general public, for nurses, for physical therapists, for fitness instructors, for doctors. You know, doctors are as in the dark about this as anyone else. And this is an epiphany I had after doing quite a bit of work in West Africa repairing something called an obstetrical fistula. We go once a year to Niger, which is an interesting place. Possibly the poorest country on earth. We'd go once a year and we'd fix this maternal birth injury, which occurs when an unattended labor gets obstructed and a hole is created between the bladder and the vagina, making these otherwise healthy young women completely incontinent. Anyway, it's a devastating problem to live with. And so we'd go and we'd fix 200 or 300 of these fistulas a year. And although we were able to restore the anatomy in 80% plus cases that we did, a lot of these women remained incontinent. And it challenged the notion that continence is a mechanical phenomenon, right? As a urogynecologist, the way I was trained is that continence relates to the mechanical function of the bladder neck, the urethra, and the bladder, and how that responds to coughing, sneezing, and laughing. And that fits really well if your solution is a sling, right? That fits really well with the surgical paradigm. But if restoring anatomy doesn't restore continence, then it challenges the structure function paradigm that says surgery is the solution. And so, you know, I'm a slow learner. I had to go 6 times before I really figured this out and decided to come home and try and create a fitness solution for what was now evident to me was a fitness problem. And that's where the Pilates, P-F-I-L-A-T-E-S, the Pilates method, pelvic floor Pilates, some people call it, came from. We studied 120 movements in women that had no experience with Pilates per se, and selected from that array of movements 10 that really provided good engagement for the pelvic floor. And, you know, the rest is history, as they say. We made a DVD initially, and then we trained thousands of instructors, and then developed a technique whereby we can analyze movement using video synchronized to multi-channel EMG to pick out each individual's best 1 or 2 movements so they can focus just on those. And guess what? Our clinical results are just as good as surgery, except there's no surgery, right? No implantation.
Yeah, right. No downside, no scar tissue, no invasive downsides. Yeah, I was actually, it was interesting. I was having this conversation with my 16-year-old son, and we were talking about some of the topics at our Functional Aging Summit. And I said, well, we're going to have a urogynecologist on. And of course, 16-year-old sons always are like, wait a minute, I don't know if I want to hear about this, right? I said, well, actually, it's important. You know, we were talking about pelvic floor issues and incontinence issues, and he was like, how do you train? I mean, his first question was, how do you train that? and then he was like, you can, and then he sort of looked at me like, personal trainers train that, right? And I said, it's actually, I mean, it's critically important. I mean, if you're a male or a female and you're walking around with incontinence, it really doesn't matter what age you're at. It's a problem you want solved. So just give us, for those listening, a couple of highlights from your sessions you're going to do at the summit. I mean, why does a personal trainer want to attend your sessions? What are they going to learn? And what are some of the practical tools you can give them that they can start using with their clients right away? Because I know the vast majority of our clients over the age of 60 have some level of struggle in this area, whether they want to admit it or not. Certainly not all of them, but odds are what we see at our studio, almost 1 out of 2 women have some level of, you know, like you mentioned coughing and sneezing, and I hear jokes from them like, oh, well, wait a minute, don't ask me to jump up and down. I got to go to the bathroom first, you know.
Right. Well, I think you really hit the nail on the head, but, you know, when you were telling us about your conversation with your son, you know, it's, I think, the only part of the body that most people don't know they have. And if you think about it, that's extraordinary. Like, how many parts of your body are you unaware of?
Right.
Pretty incredible, right? So I call it the last fitness issue, because like it, but we don't like to talk about it. We don't like to use the language that's appropriate for it. You know, I can't tell you how many patients I see, and they come in for an initial consultation. They say, Doc, I've got a problem down there. Like there's a sick relative in Australia or something, you know. It's like, they don't want to say the word. If you did that at the dentist, they think you're insane, you know.
Right.
So we have all this cultural inhibition, right? Because, you know, we're not supposed to think about it, talk about it, discuss it in polite company, you know. And yet it is such a significant issue. Overactive bladder is second only to major depression in terms of its impact on quality of life. And so if stress incontinence, leakage with coughing, sneezing, laughing, that sort of thing, makes you, you know, not do some of the activities that you used to do and enjoy. If overactive bladder makes you not go to your grandson's baseball game because you're not sure there's going to be a bathroom available, right? You're slowly starting to withdraw, become socially isolated, and guess what? That has a big impact on quality of life. And so we need to down those barriers and be able to talk about it, use the correct language about it, and provide intelligent, sophisticated solutions that have been well considered. You know, this guy, Arnold Kegel, had some exercises named after him. He is a gynecologist back in 1940s practicing at USC, right? Anyway, he wrote this paper that said pelvic floor exercises are good. And he was right. But he wasn't like you, right? He wasn't an exercise guru. And at the same time that he was practicing, and he realized that it was good to exercise the pelvic floor, and basically suggested this so-called isometric performance where you sit in a chair and squeeze your pelvic floor muscles over and over again. At the same time that he was making that realization and publishing it for the medical community, this guy, Joseph Pilates, was rehabbing dancers basically in New York City, and understood that the pelvic floor is a part of the core. And if those two had ever met, you and I wouldn't be having this conversation today, I suspect, because they would have already done this work.
Right.
But they were, you know, opposite disciplines, opposite sides of the country, and those, you know, they didn't engage. So this is the work we're trying to do now to say, 1, the pelvic floor is part of your core. 2, the pelvic floor muscles are muscles of movement. And 3, we can leverage those first 2 things to create a more effective, sophisticated program of pelvic floor conditioning that, guess what, treats pelvic floor disorders that are the consequence of deconditioning, dysfunction, very, very effectively without the side effects and risks of surgery. That's really our method.
I mean, that's the thing that to me is impressive, because what you're trying to do is bring tools that I think for many of us would have thought, well, you have to be a surgeon in this area to help someone restore pelvic floor dysfunction. And what you're saying is, no, I can teach these tools to fitness professionals, get similar results to what we used to think was a surgical necessity. And basically you're saying we're seeing similar outcomes with the training. Is that correct?
That's exactly right. And so, you know, when you're working with any kind of, I'm sure you know, when you're working with any kind of exercise program, you've got to give people results quickly or the attrition rate becomes intolerable, right? You lose patients, clients. And so realizing that was the impetus for using the video EMG synchronization technique to pick out just their best one or two movements, forgetting about the other ones so they can focus on the movements that are going to have the greatest impact. And so when we look at both subjective and objective criteria, pre and post 28 days of training, we see that 80% of our patients, regardless of how compliant they are, this is all comers, so sort of an intent to treat, 80% achieve at least a 50% improvement in their symptoms in 28 days of training. So that's faster than a drug for overactive bladder works. It's right. If from the decision to have surgery to your post-op check, it's much faster than that. And so why wouldn't you do this? Now, some people just won't, but they should be offered the opportunity, right? They should be made aware it exists. And that's where our healthcare system really falls short, because the patients aren't getting a message that this is effective, right? And in fact, if you look at the efficacy for a modern sling procedure, it's about 80%. You know, it's similar to what we're able to achieve without doing a sling, and someone that's willing to give us 5 minutes in the morning, 5 minutes in the evening.
Yeah,
and
cool.
so that's really the medical cultural, fitness cultural change I'd like to see manifest is a reorientation about the actual nature of these kinds of pelvic floor problems.
So you're doing 2 sessions at our summit. I believe you're both doing those, doing both of those live. We will be posting that schedule. Somebody right now who's just thinking, I'm sure there's people watching right now going, oh man, I have 3 clients that need this, right? Or I have 10 clients that need this, or I have however many clients I've heard talk about this issue. What are like 2 or 3 practical things you're going to be able to give them in these sessions? I mean, why should someone be tuning in?
Well, I think, the first is what, we just talked about, is a reorientation of understanding that bladder control is a fitness issue, a pro-fitness issue, and you don't have to start with a surgical solution for a fitness issue, right? That's the first and most important reorientation. Secondly, I think that everyone who attends this, hopefully, will be in a position to become a trained Pilates instructor and provide these services effectively. It's really not that complicated. Our course, which takes a day, and will be offered online now. We were talking about that earlier. Why would we ever go back? This is awesome. This is so great. You can reach so many more people this way. And we'll give them the ability to bring it into their practice safely and effectively. The movements just aren't that complicated. So our course is kind of didactic heavy. There's more theory and sort of pelvic floor disorders from the physician's perspective, and how to engage with physicians so you can partner with them, work with them, and give them a resource that they can pass on to their patients, and help people not have to wind up in the operating room. So we'll have a Pilates training coming up online this summer, and it'll be awesome. We had one in Japan scheduled for June, and they got locked down. Well, they just decided we're going to do it online, and it turns out many more people are going to take advantage of it. We could only accommodate maybe 60 or 70 live, but now there's really no limit. And I can do this because the movements just aren't that complicated. We can teach the movement section of our course effectively.
And your course is typically a full day workshop, 2-day workshop. How do you normally deliver that?
We've done it both ways, but the best reviewed, the best client experience is one long day.
One long day. Okay, great.
That's
great.
9 hours.
And if people want more information on your course, and we certainly hope to be able to promote your upcoming courses, whether they're live or online or a mixture. Where can people go? Do you have a simple website people can kind of check out your course?
Yeah. There's 2 websites. One is the Pilates website, so PFILATES.com. And the other is the Vessi Lab website. Vessi spelled strangely also. You know, and I just made these words up.
I'll add them to the comments below. But the P Pilates is for like pelvic floor Pilates. Yeah, P Pilates.
It cracks me up when I see like Pilates or Vessi show up in a peer-reviewed journal article. I think I just made that up. That's hilarious. But but now it's a thing, right? I guess that's how things are created.
Absolutely.
Anyway,
Absolutely.
so Vessi Lab is VESYLAB.com. VESYLAB.com.
Aerobics was not a thing until, you know, Ken Cooper coined that term, and now it's in the dictionary. So, and we've all done aerobics, right? So, you got to coin the term. Well, Bruce, thanks so much for your time, and thanks so much for speaking at our summit. In the comments below, I'll have some links to his websites as well, so you can check that out. But this is an issue all of us trainers have got to get up to speed on, because it's something our clients are dealing with, whether we know it or not. At least many of them are probably struggling with it and not even telling us, because like you said, people don't talk about it, right? It's not something we talk about. And so when I was talking openly to my 16-year-old son about it, he was like, really? That's something you can train? I was like, absolutely, it's something you can train, and it's something we need to train, and it's something we need to be more open talking about too. Comfortable. It's funny, we don't have shame talking about our knee or our hip replacement, but we won't talk about our pelvic floor dysfunction or our incontinence, right? So because it's more personal and it's embarrassing, I guess. So but those are some of those cultural norms we need to break through, because as now over 100 million people in our country are over the age of 55, it's going to start to become a more common problem, and as people are living longer and longer, they shouldn't be suffering with something that, like you said, impacts quality of life so dramatically. So thanks so much for what you're doing. Thanks for speaking at our summit. And I hope this snippet gives you one more reason why you need to buy your ticket to the Functional Aging Summit online.